Thanks for having me. Just got a tour of the facilities this morning, and I think more importantly than that, just knowing about the strong intentionality of Parkinson's Voice is really impressive. So it's a great organization that you have, and I'm proud to be able to speak for it. So I was invited today to talk about treatment options for non-motor symptoms in Parkinson's disease. And I think this is an especially important topic. These symptoms are invisible. So when we talk about things like anxiety and depression and fatigue, these are things that other people may not see. These are symptoms that oftentimes fall between the cracks. People don't know if they should talk to their neurologist or their primary care doctor. They don't know if this is from Parkinson's or from getting older. And so hopefully at the end of the lecture we'll provide some clarity. Definitely feel free to write down questions as we go, and we'll try to get as many as we can at the end here. So my goals for the talk are to cover the most common non-motor symptoms so that we really know what can be due to Parkinson's disease, and it's a lot more than a lot of people would think. We'll talk a little bit about why they happen, and I think that's important when we start talking about treatments, and also to gain a better understanding of how these symptoms are related to Parkinson's. We'll talk about why they're so important for you to know about. These symptoms are bigger contributors to quality of life for a lot of people than things like tremor that get a lot more attention. We'll talk about treatment options, both medicines and non-medical treatments. And then I think also importantly, talk about how we can manage or cope with these symptoms even if we can't make them go away. A day of technical difficulties here. Nope. All right, so important things to know. So first of all, as I said, that people around you may not recognize these symptoms, and that includes your doctor. And so one of the things that I think is an important takeaway is that if you're experiencing these symptoms, and actually this is a good practice, is that you may want to come to your doctor with a list of questions and things that you want to cover. Because they are going to pay attention oftentimes to what they see, and we know, for instance, with depression, that the most common reason depression is not successfully treated in Parkinson's is not because we don't have good medicines, but it's because the doctor didn't know somebody had depression. So really important that you bring these up with your doctor. I think it's also important to understand that these symptoms are really part of Parkinson's disease, and that as our understanding of Parkinson's grow, that we understand that Parkinson's is not just a motor disorder, but it also includes these non-motor symptoms, and so that's part of the definition of Parkinson's now. These symptoms affect quality of life, they affect your function, they affect your relationships with others. And importantly, and the focus of this lecture is that these symptoms have treatment. And so I hope at the end of the lecture today that you leave with some hope and some ideas of ways to manage it. Also importantly, I'm going to read off a whole lot of different symptoms. And when I have people come in and do research studies with me and I'll ask them about things, oftentimes I'll say, well, I don't have that one yet. And I want you to know that just because something is on the slides does not mean that this is something that you're going to have in your future if you don't have it. And in fact, I don't know anybody who experiences all of the non-motor symptoms. So if you don't have it, you don't have to worry about it. And there are some things that can happen with time, but a lot of these symptoms, if you don't have it at the beginning of the disease, you'll never have it. So don't get too worried if you see something there that you don't like. And then the last thing, and we'll go over these again at the end, is that there are some strategies that people can use to better live with certain symptoms. And so we'll talk about ways that we can build resilience, that we can manage these symptoms, and that we can learn to cope. So these are the motor symptoms of Parkinson's disease. These should be familiar to everybody. This is what I get taught in medical school. So these include tremor, slowness, or the fancy word is bradykinesia, stiffness or rigidity, and problems with balance. And then these are the most common non-motor symptoms. So I think the first thing that should be apparent is that there's a lot more non-motor symptoms than there are motor symptoms. And we're going to go into these in detail, but just to tell you with this slide that over 90% of people with Parkinson's will experience one or more non-motor symptoms. I think the average is about 4 to 5 non-motor symptoms. So these things are very common, and we'll go through these in more depth as we go. Back up one, yeah. So non-motor symptoms, why do they happen? So as our understanding of Parkinson's has evolved over time, we now know that Parkinson's disease is a process that starts years, if not decades, before the first motor symptoms. And there's some newer research that suggests that Parkinson's may start in some of the neurons in the gut or in the salivary glands, and then it works centrally. We are now talking about what are called premotor symptoms of Parkinson's. One of the most common ones actually is changes in sleep patterns. So sometimes people will have changes in their dreaming, changes in acting out dreams, people can have fatigue, changes in mood, and these things can happen years before Parkinson's disease gets diagnosed. Symptoms like constipation, actually even as early as high school, predicts later risk for Parkinson's disease. So these are definitely part of Parkinson's, and people in the crowd here may have heard of alpha-synuclein, which is a protein related to Parkinson's disease or Lewy bodies, but alpha-synuclein can be detected in neurons outside of the brain, and it's thought that it progresses into the brain. That's what this slide is from the Brock staging system, and talks about preclinical Parkinson's happening years to decades with alpha-synuclein accumulating elsewhere and then working its way up to the brainstem. So the second thing that I think is important, and this definitely ties into treatment, is that Parkinson's disease affects more than dopamine. So we're all familiar with dopamine and levodopa and dopamine agonists, and that's a big part of what we focus on in Parkinson's. And Parkinson's disease absolutely affects the dopamine neurons in the substantia nigra, and that's what causes a lot of our motor symptoms. But Parkinson's affects almost all the neurotransmitters in the brain. Acetylcholine is a neurotransmitter that's very important for memory, and when we talk about memory, we'll talk about some medical strategies that try to boost that. Serotonin, which people may have heard of with selective serotonin reuptake inhibitors or SSRIs like Prozac. That's affected by Parkinson's and can affect things like depression and anxiety. Norepinephrine, also called noradrenaline, is important for energy and is part of cognitive focus. And melatonin is important for sleep. And so all of these neurotransmitters are affected by Parkinson's disease. And so when we talk about treatment strategies, we want to keep these things in mind because a lot of these will not respond to dopamine treatments, but they may respond to other treatments. The basal ganglia is also important for more than movement. And so you may have heard in other lectures, the basal ganglia, which includes the globus pallidus and the subthalamus nucleus. So those are the targets that we put electrodes into the brain for deep brain stimulation. But the basal ganglia does more than just control movement. So the basal ganglia and these circuits that you've seen in other lectures are also important for coordinating thinking and memory. Just like we have what's called bradykinesia, which is slowness of movement. There's bradiphrenia, which is slowness of thinking. And that has to do with these circuits. These circuits are important for sensation and can be related to pain. And so the basal ganglia is also something that, again, we're expanding our understanding of what it is. We also know some of this because if you put the deep brain stimulation electrode in the wrong place or program it wrong, you can have other side effects. So sometimes people can have changes in mood with deep brain stimulation or changes in speech with deep brain stimulation. And we also know that Parkinson's affects multiple parts of the brain. So again, in the typical motor lecture, we talk about the substantia nigra, which makes dopamine, and the basal ganglia. But we now know that Parkinson's actually affects other parts of the brain. It can affect the outer part of the brain called the cortex, which is important for thinking and memory. It can affect parts of the brain that are important for mood and emotions. It affects parts of the brain in the brainstem that are important for sleep and for control of our autonomic or automatic nervous system. And then Parkinson's has effects outside of the brain. And we'll highlight a few of these, but Parkinson's patients are at higher risk for melanoma, which is a skin cancer. Parkinson's patients are at higher risk for osteoporosis, which is a big deal because Parkinson's patients are also more likely to fall, so we have to worry about bone health. People with Parkinson's disease can develop changes in their joints, for instance, in the joints of the hand, in part because of the muscular changes. There's changes in the gut with Parkinson's disease. And so again, we have to really broaden our conception of Parkinson's disease if we're going to incorporate that big list of non-motor symptoms. And we covered that. And then the last thing that I think is important to talk about is recognizing that Parkinson's affects multiple areas of your life. And so some of the non-motor symptoms are not because of the what we call the pathophysiology or the pathology of Parkinson's, but it's because of how Parkinson's affects your life. So Parkinson's affects how we move, Parkinson's affects our function, and when we talk about pain, we'll talk about that if you're not doing full range of motion exercises, for instance around the shoulder, that you can get tight shoulder and develop frozen shoulder. So you can have a non-motor symptom pain that's coming about because of changes in movement and function. If you're sleeping differently, if you're having problems with mood, that can affect social relationships. Mood definitely can affect thinking and memory, and so a lot of the non-motor symptoms can feed off of each other. One of the things that I often do when I talk to patients is that we'll find people who are kind of in a negative feedback loop, where they're having problems with pain that's affecting their sleep, that's affecting their mood, and so we really try to target things, for instance, try to get their pain better so that they can sleep better and improve their mood, and try to get people into positive feedback loops. There's changes in people's roles and identity, so people will, and I think this is true of everybody, that we oftentimes define ourselves by what we've accomplished in our lives, what we're able to do, what our role is in the family. And as those things change, they can affect our sense of who we are as a person, and that can definitely affect our mood, that can affect our willingness to take chances, to reach out, to be with people. And so again, these things are important, and I think they're particularly important when we talk about how do we cope and manage and build resilience with this illness. Also, I think before leaving this slide, there's a lot in the Parkinson's world, which I'm sure you've seen, about living well with Parkinson's. And I'm all for that, and I'm all for positive thinking, but I also think that we do need to have some room to experience grief and loss and talk about the difficult side of Parkinson's. And I think if we don't have an outlet for that, it oftentimes becomes difficult to move forward in a positive way. So we want to make sure that we have a balance and that we have space and understanding to do that. So I'm going to start with these with thinking and memory. This slide says I have a photographic memory. It takes about at least an hour to develop. Based on that definition, how many people here have a photographic memory? So I like this slide for a couple of reasons. And I think this slide really highlights one of the differences between Parkinson's and Alzheimer's disease. So in the next slide I'll talk about how we define dementia, but I think it's important to know that people with Parkinson's disease can and do develop dementia, but dementia is not the same thing as Alzheimer's disease. And in Parkinson's disease dementia, it tends to be more like this slide, that you have a photographic memory, it takes longer to do things, but there's still film in the camera. Whereas in Alzheimer's disease, there's not film in the camera, and it looks differently. So not all dementia is the same. And I think that's one thing that a lot of people, when they hear about Parkinson's disease, when they hear about dementia, they have this idea in their head of being in a nursing home, not being able to recognize their loved ones, and that typically does not occur with Parkinson's disease dementia. It can, and sometimes people with Parkinson's dementia have a very difficult and challenging course, but oftentimes it looks different than Alzheimer's. So I want to clarify some terms, because these can be confusing. So normal cognition, and cognition is just a fancy word for thinking and memory, or age-related changes in thinking and memory, is something that everybody experiences, and actually it starts changing at the age of 25. So everybody will have changes in thinking and memory as they get older, and so it's not uncommon to have a little bit more difficulty finding the right word, what we call a tip of the tongue phenomenon. It may be difficult to find the names of people. We may every so often go into a room and forget what we got into that room for, and those things are all things that can happen just as we get older. Mild cognitive impairment means that people have changes in thinking and memory that are more than we would expect just based on their age. And in Parkinson's disease, the areas that are most affected are executive function, which means your ability to plan, your ability to multitask, the speed of thinking, your ability to pull out memories, language, and then memory, but more so pulling out memories rather than laying down memories. And this is common in Parkinson's. At the time of the diagnosis of Parkinson's, about a third of people with Parkinson's will have changes in their thinking and memory that are more than we would expect just based on their age. And some of that is this bradyphrenia. When I see people who are professionals, like lawyers or doctors or engineers, those are often the reasons why they have to stop work, is because of these changes in thinking and memory. So they don't have dementia, but they are just not as fast and as sharp as they used to be. Dementia, by definition, means that you have problems with thinking and memory that are so severe that you can no longer care for yourself. That's the definition of dementia. And I bring that up, I often use the story of my mom. So my mom will ask me every month if she has dementia. And she can tell me everything that she's forgotten over the last month. She is able to remember that. And she does not have dementia. So she has just normal age-related changes. And part of the reason I bring that up is it's really important to get your memory tested, to make sure that you have an accurate outside observer telling you, because it can be sometimes difficult that, my mom's on one side of the continuum, On the other side, we'll see people with severe dementia who come to our clinic, and when we ask them if they have any problems, they're like, I don't, it's these other people in the room. And so people are not the best guides to evaluate their memory. The other reason I bring up that definition of dementia is that dementia has many causes. Parkinson's disease is one cause of dementia, Alzheimer's disease is one cause of dementia, and then I'll go over some of the things that are actually treatable and reversible causes of dementia. So it's important, so people may not realize this, but dementia is the leading cause of nursing home placement in Parkinson's disease. And in studies that were done 20 years ago, and I think the numbers would be lower now, up to 75% of people with Parkinson's over 20 years could develop dementia. I think those numbers are going to be lower now because we do a better job of focusing on exercise, which is the most important thing you can do to reduce your risk of dementia, but nonetheless it's a big issue. Thinking and memory affect all aspects of function, including things like driving, including things like remembering to take medications. And I think also importantly that some aspects of it may be treatable or reversible, and if not, at least things that we can work with. So these are reversible causes of dementia. So certain medications, and the ones that I see most commonly in my clinic are sleep medications like Tylenol PM. The PM is from Benadryl, and medications that block acetylcholine, like Benadryl, like certain bladder medications, as we talked about earlier, are going to exacerbate memory problems. And so that's probably the most common thing that I'll see in my clinic if I'm going to hit a home run and improve somebody's memory would be from a medication. People who have chronic sleep deprivation, that's going to affect thinking and memory. Depression can affect thinking and memory. In fact, there's something called depressive pseudo dementia, which is that people with chronic depression will have changes in thinking and memory that can look a lot like Alzheimer's disease. And when their depression is doing better, their thinking and memory can improve. And lastly, there are other medical conditions such as low vitamin B12, thyroid disease, liver disease that can present with dementia. And so it's important when you start having problems with thinking and memory to talk to your doctor about it. Again, don't let these things be invisible, so that if there is something reversible, that it can be caught early and treated. So it's important to get your memory tested. And I put here a MOCA. So there's something called the Montreal Cognitive Assessment, which is the MOCA. And that's a 5 to 10 minute test that your doctor can do in their clinic. And that gives you a pretty good idea of where things are at in terms of your thinking and memory. They might decide to do something called neuropsychological testing, which is typically 2 to 4 hours of more in-depth memory testing. But again, it's important that you test your memory, that we don't just ask people how their memory is doing. And in fact, we know that when we ask people how their memory is doing, that does not correlate actually with memory tests. It correlates with their mood. So people with more anxiety and depression tend to perceive their memories worse, but it doesn't necessarily show up as worse on tests. Exercise is incredibly important for thinking and memory. And so people ask me all the time, should I do brain games or Sudoku or whatever? And so the bottom line with exercise is that the best evidence for slowing down progression of thinking and memory problems is actually aerobic exercise. And so getting your heart rate up, it has been shown to increase nerve growth factors in the brain, to increase stem cells in the brain. There's also a study recently looking at strength training in Parkinson's, showing stabilization and some improvement in thinking and memory. So that's an incredibly important thing that you can do for your thinking and memory. Also important is being mentally active, and I think the most important thing with being mentally active is finding something you like doing. So if you like Scrabble, if you like learning a new musical instrument, if you want to learn a new language, really anything that's going to test your brain, the kind of idea is use it or lose it. And so you really want to try to stay mentally active. And the last thing which I think is important, and I actually learned from a Davis Finney Foundation talk, is staying socially active. So I really like the group clinics that are being done here around voice, but there's several studies showing about the idea of social capital. And so social capital is the amount of social connections you have, and with Parkinson's disease, there's a strong tendency for that social capital to shrink. That you don't see the people you used to work with, you don't see people you used to play racquetball with, and pretty soon it's just you and your caregiver. And the risk of death for people with poor social capital is the same as if they had taken up smoking. So it's a big effect. So really important to stay socially active and socially connected and fight the very strong tendency, which I understand, to be isolated. Other therapies that are out there are a class of medications called acetylcholinesterase inhibitors. And I'm putting down the generic names for everything. So rivastigmine and donepezil are also known as Exelon and Aricept. Those are some of the more commonly used medications. Sometimes people will take these medications and they'll notice a difference. But a lot of times people will take these medications, they don't know anything, but what we know from studies is that it may help slow down the progression. So for people with early and mild dementia, these may be medications worth taking. There have also been studies saying if using these medications in people with mild cognitive impairment reduces the risk of dementia, and it doesn't. So there's no reason to take these early. If you're concerned about dementia, exercise, but there's no evidence that taking these medications earlier is better. Memantine, also known as Namenda, is another medication where there's some evidence that it helps slow down the progression and may help thinking and memory. Physical exercise, cognitive exercise, social activities, and the last thing I put here is laughter. There was actually a study at the University of Florida that I really liked where they compared physical exercise plus cognitive exercise to a group of people who were using the Wii Fit. And if people want to guess which group did the best? Yeah, people in the Wii Fit. And what people observed was that the people in the Wii Fit group were laughing, they were having fun, and so this is something I think we tend to ignore. In medicine we're very serious about things, but I think, laughter, having social connections, doing things that are fun is actually hugely important. Other coping and management strategies. So one thing I put here is focusing on the positive. I don't know if people here have seen a movie called Alive Inside. If you haven't, it's an amazing, great documentary about a person in New York who made it his mission to bring personal music to every person in America living in a nursing home. And it's an amazing movie about the power of music, and particularly about the power of personalized music, so music that people actually enjoy as opposed to the music that's oftentimes piped in nursing homes. But if people are listening to the music that they really love, it really turns them on. And so I was interviewed about that movie, and one of the things I said during the interview, and this is how I work with people with dementia, is that with dementia is a disability, and it's a disability of thinking and memory, and with dementia you can, I use the analogy of Swiss cheese, you can either focus on the holes or you can focus on the cheese. And so even though there are things that are missing in your life with dementia, there are still things that are very much intact and whole. And that's kind of become, a little bit of a joke at the University of Colorado where I am, is that people are focused on the cheese. Because we do, even with dementia, there's still a lot of person that's still there. We don't want to lose sight of that. Going back to that slide earlier about the photographic memory, is that you can use aids, so you can use notes, you can use your smartphone, you can use other things to help get around some of the problems with your memory. So that's something that can be done, and cognitive psychologists or others can help with that. Staying active and engaged is very important, as we talked about. And it's important not just for thinking and memory, but it's important for living your life and for feeling alive despite having a lot of losses. And then lastly is finding ways to stay connected to who you are and who you love. And so we'll talk about that with cognitive deficits, and dementia tends to be one of the biggest threats, I think, to people's sense of personhood. And so as people develop problems with thinking and memory, or if they develop frank dementia, it's really important that they stay connected to who they are. And that could be through listening to music, that could be through going to church, that could be through spending time with your family, that could be through volunteering. But I think it's really important that we don't lose sight of who that person is as a person, and that we continue to work and adapt to make sure that we don't depersonalize that person. Because it's very easy with Parkinson, but even easier with dementia, that we kind of forget that people are still there. So moving on to sleep and energy. So the symptoms include insomnia, and insomnia I divided up into problems going to sleep, so sleep initiation, problems staying asleep or sleep maintenance, and then early morning awakening. And so any or all of these things can affect people's sleep, but I divide them up that way because the treatments for them are different and the causes of them are different. People can also have, with or without other sleep problems with sleepiness during the day. They might not feel rested when they wake up in the morning, and then fatigue is something different. So fatigue is that you don't have energy to do things, everything feels like an effort, but you're not sleepy. And taking a nap, you don't feel like your energy comes back. So that's what I mean by fatigue. So it's important because, first of all, sleep affects nearly everything. Sleep affects thinking and memory, sleep affects mood, sleep affects your motor symptoms. That if people have a good night's sleep, their balance may be better, their walking may be better. So we really want to make sure that people are sleeping well. Secondly, Parkinson's is a 24/7 disease. So Parkinson's doesn't stop at 8 p.m. and then come back at 7 a.m. when you wake up. And so we need to make sure that we keep that in mind, that we treat Parkinson's symptoms at night. If somebody is having stiffness or pain or tremor at night that's affecting their sleep, we need to make sure that they have medicines for that. And lastly, and I think importantly, that these symptoms are treatable and not just with a sleeping pill. And in fact, some types of sleep disorders can be made worse by certain types of sleeping pills. And so we want to make sure that we know what the cause is in order to get the right treatment. So some very common sleep problems in Parkinson's disease. One is, the fancy word is nocturia, which means getting up to pee in the middle of the night. And there's things that we can do around that, and I'll talk about those more when we talk about urination. But for instance, limiting the amount of fluids that you have at night, certain medications can reduce that. Anxiety and depression can both affect sleep. Anxiety tends to cause insomnia or sleep maintenance, that your thoughts are racing and you can't get them to shut down. Depression very commonly manifests as waking up at 3 or 4 in the morning and not being able to go back to sleep. Pain is a very common cause of problems with sleep, and we'll talk about pain more later, but people can have leg cramps that interfere with sleep. People can have pain in their shoulder or neck or stiffness that can interfere with sleep. Untreated Parkinson's disease can interfere with sleep, so people don't move, they're stiff at night, they're uncomfortable. Nightmares can come up, and that can also be a cause of problems with sleep. And then dyskinesias, or having too much medication, can also interfere with sleep. So these are all things to keep in mind that we would treat directly that can help people to sleep better. People with Parkinson's can also have very specific sleep disorders. So restless leg syndrome, or RLS, is a syndrome where people have a restless sensation in their legs. It can feel kind of creepy, crawly. And this tends to happen before people go to sleep. So while you're sitting and watching TV, while you're still, that's when restless leg syndrome comes up. So it doesn't come up after you're asleep. This is something that happens before you're asleep. Periodic leg movements of sleep is kicking around and stuff after you're asleep. So those things are related but different. REM behavior disorder, or rapid eye movement sleep behavior disorder. So REM is the part of sleep where you dream. And normally when people dream, there's a disconnection between your brain and your body, so that when you're fighting crime in your dream, you're not fighting crime in the bed. But with REM behavior disorder, that breakdown doesn't happen, and so somebody might have, I had a great night last night, I was fighting crime and whatever, and like, oh, I know. And you're getting punched and kicked if you're that person's bed partner. And so that's actually one of the earliest symptoms that we can see in Parkinson's disease, and oftentimes comes even a decade before other symptoms. And then sleep apnea are problems with snoring or breathing in sleep. And with sleep apnea and Parkinson's, usually we think of sleep apnea in people with a big neck or who are overweight, but in Parkinson's disease, that's not necessarily the case. So initial steps, so I always, if people have these issues, we'll take a careful sleep history. And if people have a bedmate or a bed partner, I'll talk to that person to find out a little bit more about what's happening at night. Sometimes people with sleep apnea or REM behavior disorder sleep 8 hours, 10 hours, 12 hours. They don't remember anything going on at night, but they don't feel rested in the morning, and the person sleeping in the room with them definitely doesn't feel rested. Important to check medications. So insomnia can be caused by taking amantadine late in the day. So amantadine, this happens a lot. It's written for twice a day, and so people take it in the morning and at night, but it really should be morning and lunchtime, and that taking it too late in the day can interfere with sleep. Donepezil or Exelon, some of those medications that I talked about for memory, can cause nightmares. MAO inhibitors like rasagiline or sledgeline can sometimes cause insomnia. And then daytime sleepiness can be caused by medications. Dopamine agonists, so things like Requip and Mirapex and Nupro, can even be associated with sleep attacks where people will fall asleep at the wheel or fall asleep in the middle of the day, so that's important to know about. And then Cinemet or carbidopa-levodopa can sometimes be associated with sleepiness. Other causes of fatigue, it's again important we don't miss things. So if people have anemia or low iron, low thyroid, low testosterone, chronic dehydration, all of those things can cause fatigue. And then again, it's really important to stay active and to exercise. I'll talk about this more specifically with fatigue, but also sleep hygiene. And what sleep hygiene is, and you can go online and read about it, but it's just this idea of developing good habits at night. And so some of those ideas are to not have too much screen time later in the day, to use your bed not for watching television, to just use it for sleep, to not have caffeine or other stimulants later in the day, to try to limit fluids so you don't have to get up at night. So those are things that would fall under sleep hygiene that can be helpful. As far as specific treatments, so for REM behavior disorder, for acting out dreams, an easy place to start is melatonin. That can sometimes be helpful. There's also a medicine called clonazepam that tends to be very effective for quieting down sleep problems. For sleep apnea, if people have that, then Cpap, which is continuous positive airway pressure, or BiPAP. So these are things that keep the airways open, and wearing a mask for oxygen can be helpful. There's also sometimes mouth guards that can be used, or putting a tennis ball so you don't sleep in different positions. For RLS, actually a lot of the medications that we use for Parkinson's are also helpful for RLS. Gabapentin, clonazepam again, and then narcotics, so things like Vicodin or Norco and Percocet can also sometimes be helpful and can sometimes be used for restless leg syndrome. For nocturnal leg cramps, a cheap and easy thing that oftentimes works very well is magnesium. So I'll usually recommend 400 to 500 milligrams of magnesium at night. It can sometimes really help. Tonic water with quinine can oftentimes be very helpful. Certain muscle relaxants, and I don't know if this is going around here, but I've heard from a lot of support groups that having a bar of soap at the foot of the bed, yeah, so there's people here who are swearing by that. I don't understand why that works, but nonetheless, that's the word on the street, is putting a bar of soap at your feet will help muscle cramps. Ivory soap, okay. Fatigue. Exercise is important, and for fatigue, I actually recommend people do some strength training. And so the idea with doing strength training with fatigue is that if you can build up your muscle mass and build up your capacity, you have to use less energy to do things. And so both aerobic and strength training, but a lot of the research shows that strength training may actually be a little bit better for fatigue than other types of exercise. And stimulant medications, so things like methylphenidate or Ritalin, can sometimes help people with fatigue by helping their mental focus and attention and sharpness. And then for daytime somnolence or sleepiness, if there's not a sleep disorder, sometimes medications like modafinil or Provigil, is the other name for it, can be helpful. In terms of other ways to cope and manage, so self-hypnosis are techniques basically just to teach yourself how to relax at night. And teach yourself how to cope better when you're waking up in the middle of the night, to not freak out, to not get too upset about it. Maybe go do something else and come back to bed and then work on that. Energy management is an idea, is that you have a certain amount of energy that you're going to have throughout the course of the day. And so you want to use that energy to the best of your ability. And so if you have your best energy in the morning, you might plan to do exercise in the morning so you can get those things done. You might try to spread out your energy over the course of the day. You want to try to not do too much so that you're not paying a price for doing too much 2 or 3 days later. So that's this idea of energy management. The power nap is something that I think is underutilized, but having an afternoon nap for 15 to 30 minutes can be very energizing and can be helpful. And then sometimes shifting schedules. So one aspect of sleep hygiene is to try to stay on a same habit. And so to go to bed at the same time every day, to wake up at the same time every day. And sometimes if people are night owls or they're morning people or whatever, is that you may want to kind of shift your schedule so that you can make the best use of your energy and not try to fit your schedule to meet everyone else's. Okay, so shifting gears now to mood. And I like this picture because mood, and particularly depression and anxiety, really change the way you see the world. And can affect almost every aspect of a person's life. When I see people in clinic, and we've adjusted their medications, and I think they're looking pretty good, and they tell me that they're not doing very good, oftentimes it's not a motor problem, it's a mood problem. And again, it's because of how they're perceiving things. So what are the symptoms that we see? So depression, and I'm going to be kind of strict in how I'm defining depression. So depression is really that you have a loss of interest in things, that you have a loss of ability to enjoy things, that you're feeling sad, oftentimes for no reason, and this is really a chemical imbalance in the brain, and it's one that is affected by Parkinson's, which affects serotonin. And I bring that up for a couple reasons, because sometimes people have shame around having depression, they have shame around taking medications for depression, but it's really no different than taking a medication for your tremor. So we're just trying to balance some chemicals that are off balance in the brain. Anxiety in Parkinson's, also a big problem, and depression can affect about 40% of people with Parkinson's, same thing with anxiety. And anxiety can come in a few different flavors. So general anxiety disorder is where people kind of feel nervous and tense almost all the time, they don't have a good reason for it. Social phobia is being particularly nervous and anxious in social situations. And sometimes this gets justified of, oh, I don't want to be around people because of my tremor or things like that, but it's important that we don't let that be an excuse, because remember what I said about social capital, we don't want people to be isolated. And then the last thing that we can see is panic attacks, and these are very sudden instances of severe anxiety or terror. There it feels like people are having a heart attack, it feels like the world is collapsing. And then apathy is something that's kind of unique to Parkinson's disease, and it's different than depression. Apathy is a flattening of affect, meaning that there's not a lot of happiness or sadness, and also importantly, there's a loss of motivation. And by physicians and by family members and even patients, sometimes people mistake apathy for depression. And it's important to recognize that when people have apathy, they're not feeling sad, they're not feeling guilty. It's just pretty flat. And sometimes medications that we use to treat depression, like SSRIs or Prozac, can make apathy worse. So it is important to make sure that we distinguish them, and how we treat them and manage them is very different. I also want to make sure that we don't lose sight of other normal, difficult emotions that come up with Parkinson's disease. So people with Parkinson's can experience grief, meaning sadness from things that we've lost in our lives, things that we're not able to do, anticipatory grief, or thinking about the future and how things are going to change over the future, and that's normal. And that's something that we can talk about and deal with, but I want to make sure that people understand that that's normal and that's not depression. People can feel guilty, particularly they can feel guilty for being a burden on their family or needing care. People can feel demoralized and hopeless with Parkinson's disease. It's an incurable illness, it's going to get worse every year, what's the point of even trying? And how do we work with that, and how do we kind of restore a sense of hope and restore a sense of meaning when people are experiencing that? People can be frustrated with Parkinson's, they can be angry with Parkinson's, isolation, loneliness, so these are all normal, difficult emotions that come up with having a bad illness. And we'll talk a little bit more about how to work with those, but I think it's important to name them and to understand that these are not a pathology, this is not depression. So it's important because mood affects so many things, and I put this here that you deserve help. So I think a lot of people feel ashamed about bringing these things up. They feel like they need to be tough and work their way through it. And I want to tell you that when people are able to open up and get help for these things, it can make a big difference in their quality of life. And these symptoms are, for the most part, treatable. So for depression, I put down a bunch of different medications. So there are SSRIs, selective serotonin reuptake inhibitors, and these include medication like Prozac and Zoloft and Paxil. There's selective serotonin norepinephrine reuptake inhibitors, which is a big word, but things like Cymbalta and Effexor fall under that category, and those things can sometimes help with pain as well as depression. There's other medications that are out there. There's a class of medications called Tricyclics, which have been used in depression, in Parkinson's disease. Can be helpful, but you need to be careful about side effects with those medications. Mirtazapine or Remeron can be helpful, particularly for people who are having problems with appetite or sleep. And then bupropion or Wellbutrin can be very helpful for people who are having problems with apathy and depression at the same time, or fatigue and depression. Psychotherapy or counseling is equally important, and there's a number of studies, including in Parkinson's, showing that counseling and medications are better than either one by themselves. One of the things with counseling to be aware of is that you want to find the right match for a counselor. A lot of times I'll bring this up with patients and they'll say, yeah, I tried that and it didn't work out. And it didn't work out with that counselor. And so you need to find a good match and find somebody that you can talk to, and then counseling can be helpful. Cognitive behavioral therapy is one type of therapy that can be very helpful for both depression and anxiety. Exercise is important for depression. And it can be physical exercise. I think also social exercise and staying connected is important. And then mindfulness. And we'll talk about this more in a little bit, but being able to focus. I think the underlying principle of attention here is very important. Being connected with meaning, making sure that people don't have too much social isolation, and are staying socially connected. So you really have to be active, if you have depression, to fight depression. You can't let depression win, and you have to often bring in other people. Again, don't keep it to yourself. Share it with other people so that you can get the help you need. Anxiety, a lot of the same treatments that we use for depression are also used for anxiety. One thing to mention is that panic attacks can be a symptom of wearing off of levodopa. So if people are having anxiety and it seems to be time to when their medications are wearing off, you can sometimes adjust that medication to help with that aspect of anxiety. And this kind of ties into something called the somatic theory of emotion, which is that we feel anxious because our bodies are anxious. So if we're tense, if we're trembling, that could make us feel anxious. And so a lot of the symptoms of Parkinson's disease can trigger anxiety, and so we need to recognize that there's kind of this two-way street. Also, anxiety can make Parkinson's worse. So if we're feeling anxious, that can make the tremor get worse. And so we need to be cognizant of that so that we treat the right thing. Other medications that we sometimes use include benzodiazepines. So medication Xanax or alprazolam can be very effective for panic attacks because it kicks in fast. Sometimes we use the medication clonazepam, which is longer acting when we're starting medications for anxiety, because that will also work fast for people. Counseling, again, is usually important, as is exercise, as is mindfulness. Apathy is something that I think is problematic more for families oftentimes than the patient. I have a slide that I sometimes put up about apathy, and the person says, I was trying to figure out if I had apathy, and then I recognized that I don't know and I don't care. And so for people with apathy, it's oftentimes not a problem, but it is for their family and for the people around them. Have people seen the movie Awakenings? Okay, so people haven't. It's a great film, and it talks about the discovery of levodopa. But one of the reasons I bring it up is that there are some scenes in the film that I think really illustrate nicely that there are two systems in the brain that are important for movement. So there's a system in the brain that's important for external movement. So for instance in there, if somebody throws a ball, people can catch it. Or if somebody moves, people can respond to that movement. We do that with, with dance. We can use music and that external cue. And so that system in Parkinson's disease is relatively intact, and oftentimes the internally guided system is less effective. And so in order to walk, I can't just decide to walk, I might have to count my steps, and that can help. Same thing with apathy. So if people are experiencing serious apathy, they will oftentimes do better if there is external routines and habits, and they can follow those even though they may not generate those themselves at the beginning of the day. So I think routines are really important for apathy. Another thing is changing expectations. And again, this kind of goes against our culture that we want to fight everything. We're going to fight cancer, we're going to fight Parkinson's disease, we're going to fight apathy. But sometimes there are battles that are not worth fighting. And so sometimes one of the things that we do when we see patients who have significant apathy is we figure out, what are our expectations, what's the new normal, and how can we live more happily with that? And sometimes that just takes a huge amount of relief off of people. I have a lot of caregivers who want to be the perfect caregiver, who want their patient to be the perfect patient, and they're driving themselves crazy trying to get them to exercise for a half hour every day or things like that. And sometimes, acceptance is going to be the easier and the better path, and it ends up with not only the same results, but oftentimes better results because we're able to work with what a person's able to do. So working with difficult emotions, I put this slide up. So Prozac's not always the answer. It says, can we up the dosage? I still have feelings. And I think that's our medical community's response to difficult emotions. I think that's a very kind of American, maybe particularly Texan response to difficult emotions. But it's not a very healthy response. And so when we talk about things like guilt and grief and fear of the future and fear of dementia, I think the first place to start is this acronym called NURSE, which is that we want to name that emotion. So sometimes in our clinic, if we identify something as grief and we explain what grief is, that can bring a sense of relief. We want to work to understand it. We want to explore it. We can talk about it with others. We can support people through that. But I think this is a very important part of working with difficult feelings. Is that it tends to, if we suppress it and we ignore it, they tend to grow. So we really want to try to get to the bottom of them. I think it's important to connect with others and to share feelings, that when we keep it to ourselves, they're oftentimes a lot more hard to deal with and they can become unmanageable. I think really important to find sources of strength and sources of meaning. So when people come to me in clinic and they're feeling hopeless, I'll ask them, what have you done in the past that has worked for you? What are your sources of meaning in the world? What are your sources of joy? And can we find opportunities to reconnect with those things, even if we're not connecting in the same way that we used to. Spirituality is also something that I think is hugely important. It could be prayer, it could be being with nature, it could be finding other ways of meaning. But I think this is an opportunity to connect into our spiritual beings, and that can be a very important and powerful way to work with emotions. In Colorado, we have a chaplain on our team. And he sees almost all of our patients because there's actually a quote I really like that all problems are psychological, all solutions are spiritual. And so we can use that, and we know actually our patients use that a lot, but we can use that formally to try to help work with these difficult emotions. That could be religious, it could be asking, what's God trying to tell me here? It could be, we're connecting with other sources of meaning, but I think we shouldn't lose sight of that. So moving on to the autonomic or the automatic part of our nervous system, which is affected by Parkinson's. So these are the symptoms that come about from the way Parkinson's affects the autonomic or automatic part of the nervous system. So these include things like constipation, which is very common, urinary urgency, or when you have to go, you really have to go, low blood pressure and lightheadedness, sexual dysfunction, sweating. This is something that we see come up, and then also having excess mucus or runny nose and drooling. So these are all things that can happen from Parkinson's disease. And I think these are some of the things that are most confusing for people is this my Parkinson's or is this something else? So it's important because these symptoms range from things that are somewhat annoying to things that are really life-threatening. For instance, low blood pressure can lead to falls, and so these things can be quite serious. People can also die from bowel impaction from severe constipation. They can affect quality of life in a number of ways, from simple discomfort to people's ability to be in public or to be intimate with their partner. And these symptoms are also all for the most part treatable or manageable. And so I want to spend a little bit of time talking about orthostatic blood pressure. So orthostatic means the change in blood pressure from lying down to standing. And I don't know if you can see here in this illustration, but normally when we're lying down, everything's at the same level, the blood pressure is even, and there's a lot of blood going to our brain. And then when we stand up, there's a tendency for the blood to kind of pool down into our feet. And when the blood goes into our feet and it's not going to our brain, then we feel lightheaded, we can feel drowsy, we can feel weak. And normally, when people don't have Parkinson's disease, the blood vessels will contract to squeeze more blood up to the brain. But in Parkinson's, that reflex may not be as strong. And so two things that are important about that. One is that if people with Parkinson's are dehydrated, so if there's not enough fuel in the tank, they're going to have a much harder time with lightheadedness than not. And so really important with Parkinson's disease for a number of reasons, but this in particular to stay well hydrated. And secondly, there are some medications and things that we can use to try to help the blood vessels to contract better. Lastly, and I think very importantly, is that people with Parkinson's, if they have a history of high blood pressure, they may be able to get off of their blood pressure medications because Parkinson's will also lower their blood pressure. And so it's not uncommon in my clinic that one of the first things I'll do is talk to their regular doctor to get them off of some medications that could be making this problem worse. And so this is a busy slide, so I'll kind of hit some of the highlights here. For constipation, the core treatment of constipation, so one thing is to be on a bowel regimen. And what I mean by a bowel regimen is that you're doing the same thing every day to stay regular, as opposed to not doing anything for 3 days, having really bad constipation, taking medication, having a bowel movement, having diarrhea, and then going in this up and down cycle. And so you really want to be on a regimen where you're doing the same thing every day to stay regular. And the core parts of that is going to be fluids, fiber, and exercise. There are also a lot of foods like prunes, like flaxseed, like oatmeal that can sometimes help. If you need more than that, other things that can be helpful can be stool softeners. So if you're having problems where you have painful, hard, difficult to pass stools, stool softeners can be helpful. Propylene glycol or Miralax can help things moving, and that's something that is safe to take every day. Probiotics, there have been some studies, so things like yogurt or probiotics that you get over the counter can sometimes help regulate bowel movements. Senna, which is also in teas, is also a natural thing that you can take every day to help with bowel movements. But again, the goal is to try to be on a regimen where you're doing the same thing every day and things are pretty regular. You can add to that mix milk of magnesium kind of as needed if you're having a few days where you're not having bowel movement. But again, the goal is to keep things regular, not to keep playing catch up. With bladder urgency, one of the simple things that can be done, and this has been shown to be effective, is Kegel exercises. So the same thing that pregnant women will do to strengthen the muscles in the pelvic floor can also help with bladder control. And then there are also medications, and I wrote down a few of them that I would recommend. So trospium or Cinctura and mirabegron or Myrbetriq are medications that don't pass into the brain. And there are other bladder medications that block acetylcholine and that can pass into the brain and can affect thinking and memory. So those are the ones that I typically recommend for people with Parkinson's. And then desmopressin or DDAVP is a nasal spray that we actually use for kids with bedwetting that can also sometimes help with nocturia or daytime urination. It's important with that medication to watch for low sodium though. For drooling, a place to start is sucking candy or gum because it just reminds people to swallow, and so that can be a cheap and easy way to help with drooling. Atropine eye drops, when taken by mouth, can sometimes help dry out secretions and can help. Botox injections in the salivary glands can help dry things out. And then there's a medicine called glycopyrrolate that can also help with drooling. For a runny nose, an extra mucus, guaifenesin, or which you can get over the counter, or ipratropium or Atrovan nasal spray are oftentimes helpful. For blood pressure, again, not surprisingly, fluids, and the goal would be to get 64 ounces of water a day. Caffeine is fine to take in Parkinson's, but it doesn't count for water because it's a diuretic and you're going to pee out more than you take in if you're drinking coffee. So if you drink 64 ounces of coffee a day, you're going to be more dehydrated and you probably are going to have some other problems. Elevating the head of the bed at night can be helpful so that you're not having such an abrupt change when you're getting up in the morning. Using support hose and abdominal binders to keep the fluid from getting into the legs and from dropping as much. Having an 8-ounce glass of cold water can actually acutely increase the blood pressure. And then there are medications, midodrine, fludrocortisone, and droxidopa that are prescription medications that can help with blood pressure. Lastly, sexual dysfunction. A lot of times places to start will be couples counseling and sexual counseling. A lot of times problems with sexual dysfunction in Parkinson's can resolve around issues of intimacy, can resolve around role changes where a care partner or carer feels more like a nurse than a spouse. And so trying to work on those issues. The erectile dysfunction medications, things like Viagra, definitely can be helpful and work, but that's part of the problem. Sometimes changing the way people have sex can be helpful. So if people with Parkinson's are stiffer or unable to move the same way around the hips, sometimes using your hand or other manual procedures or things like that can be helpful to kind of restore sex and restore intimacy and allow people to connect in that way. And it's important. It's something that we don't really talk a lot about. Visual symptoms. I'm going to change the slide quickly before anyone gets dizzy. So the symptoms of visual dysfunction can include problems with reading, can include problems with night vision and with driving, visual illusions. And what I mean by an illusion is that I might kind of see out of the corner of my eye a little pattern here on the floor, and then when I look more carefully it goes away. Versus a visual hallucination, which is that I might see a bunny or a dog that's standing here and I can keep looking at it and it's not going anywhere. So that's a hallucination. And it's important, so the visual problems can affect your safety, and in particular they can affect driving. These symptoms can be side effects of medications, and they also are treatable. So with visual problems, I think it's important to see an ophthalmologist or a neuro-ophthalmologist. So sometimes if people have a cataract, if they have glaucoma, if they have other things like that, that can contribute or worsen some of these visual issues. So it's important that we don't miss that. Convergence insufficiency refers to your ability to bring your eyes together, and that's important for reading. But it's also affected in Parkinson's disease, and if you get glasses with prisms, that can help bring the eyes together and it can improve people's ability to read. It's important to get driving testing. And it's also important to know, so with psychosis, so this is a spectrum. So illusions, so saying a pattern on the floor can happen with Parkinson's disease, not anything to get worried about. It doesn't mean you're going crazy. And one of the first things that I'll ask people, even with hallucinations, is whether they know what's happening. So if they're seeing a dog in the room, do they know that's a hallucination or not? And is it something that's pleasant? Is it kind of neutral, or is it really scary and bothersome? So we will have patients, and I have patients who have hallucinations, who don't know they're hallucinations, and I don't treat them because they have a hallucinatory pet, and they like that pet, and I'm not going to make that pet go away, or they have kids that are visiting them. I have one gentleman who he's watching his hallucinations every night like a soap opera, and he's really enjoying it, and so they don't always need to be treated. One of the ads for one of the medications that's out has a lot of weird and scary commercials, and I kind of think that's harmful. I mean, that can certainly be a problem for some people, but it's not a problem for everybody. It's important to know that these things can sometimes come up because of other things. So if people have a bladder infection or pneumonia, if they have a change in their environment, if they have low sodium, that can cause or precipitate hallucinations. So if people come in and they weren't having hallucinations and it all of a sudden changes, I want to make sure I'm not missing something. Secondly, I want to try to get them off of medications that might be making their hallucinations worse. Dopamine agonists are particularly bad in that respect, but other medications that block acetylcholine, amantadine, and even levodopa can affect hallucinations. And if we reach a point where lowering the medications further is making the Parkinson's worse, that's when we might add medications. I usually will start with the medicine quetiapine or Seroquel, given that it's cheap, it's been used for a while, even though we don't have great trials behind it. Most experts in the field feel that it works and it is helpful. Pimavanserin or Nuplazid, that is the medication that has been having this very active ad campaign. It's also had a lot of negative attention in the news recently from deaths associated with the medication. That's been true of other medications in this class though, and I think the evidence is that it probably is no more dangerous than anything else. The one thing that is important to keep in mind with that medication is that there is about a 10% chance of worsening hallucinations. And so it is important to know that you can have a paradoxical worsening with that medication. And then clozapine or Clozaril is another medicine that we use in this class. And it's a great medication with the exception of that you need to get weekly and then monthly blood draws to make sure that it's not affecting your white blood cell and your red blood cell count. And so it can be an effective medication, but it has a very low chance, but a real chance of affecting your body's ability to make red blood cells and white blood cells, and so we need to be careful with that. So other important stuff, and this is just another plug for exercise. It says, what fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day. So again, for everything that we're talking about, exercise is usually important. So kind of in this other category, we'll talk a little bit about pain. And I put pain on this list. So pain is another one of these symptoms where there's kind of a myth out there that Parkinson's is not a painful illness. And I see people every year who have shoulder surgery or back surgery from pain related to their Parkinson's that was not recognized, and it didn't help, and then later someone notices their tremor or something else and we realize it's Parkinson's. So with Parkinson's, about 2/3 of people, 3/4 of people will have some pain related to their Parkinson's. So that pain can be part of Parkinson's, and a lot of times is treatable. Impulse control disorders, these are things like gambling, internet pornography, shopping, other types of sexual activity, and these can be a side effect of medications. So this is under the non-motor category, and this is something that comes up from medications. Osteoporosis, I mentioned earlier, so that's a thinning of the bones. And then melanoma is a type of skin cancer. So it's important because, like sleep, pain can affect nearly everything. So pain affects your mood, pain affects sleep, pain affects your movement. A lot of times people limit their activity and limit their walking because of pain. So we really want to stay on top of that. You can prevent bone fractures, and so it's important with Parkinson's disease to work with your primary care doctor to get a bone density test every few years, to take vitamin D and calcium. And then we know this from a lot of studies that people with Parkinson's are unlikely to use the other medicines that we have available for osteoporosis if they have it. So really important to stay on top of that because you're at risk for fractures because people with Parkinson's are also at higher risk for falls. So really important to keep your bones healthy to avoid falls. And skin cancer also can be preventable by getting an annual skin check, and that could be with your primary care physician or it could be with a dermatologist. But again, you want to make sure that if you do have melanoma that you catch it early, because if you catch it late, that can be a fatal skin cancer. And then lastly, your medications can cost you your house or marriage. So with these medications, so the things like gambling, internet pornography, increased sexual activity, shopping, when you stop those medications, the gambling may go away, but the house and wife don't always come back. And so I mentioned that, and I tell people about that every time I start these medications, because those are not things that people think about as a side effect of a medication. I don't know any other class of medications where gambling is a side effect. So it's an important thing to know about. Causes of pain in Parkinson's disease. So one of the things I mentioned earlier is frozen shoulder. So one of the things that I will do when I see people in my clinic with Parkinson's, I do every time is I have them raise their hands up as high as they can above their head. And if somebody does something like this, I know that there's a problem. And so really important to try to keep range of motion, and it kind of goes to this idea of prehab. And so we want to, rather than do rehabilitation for people with problems, we want to catch problems early and prevent problems from happening. So really important to keep range of motion around the shoulders, paying attention to posture, which can be a cause of back pain, keeping range of motion around the hips. Orthopedic issues can arise with Parkinson's disease, and so if people change the way they walk, it can increase wear and tear on hips and knees. This is something that comes up in clinic, is trying to figure out, whether it's worthwhile to get a knee replacement or other things with Parkinson's. And again, going back to that last slide, the most important thing you can do to slow down the progression of Parkinson's is exercise and activity. So we really want to treat orthopedic issues if they come up. Muscle tension or rigidity can be a cause of pain in Parkinson's. Sometimes that responds to medications, and sometimes pain can be a sign of medications wearing off. So really important that we address that. Dystonia refers to kind of abnormal muscle contractions, and that most commonly involves the feet, where people have either clawfoot or have a toe sticking up. Sometimes can involve the hand. Those are things that can be treated sometimes with Botox, sometimes other medications, sometimes muscle relaxants. And then neuropathy are problems with numbness, tingling, burning, shooting pains, and these are things that we also can see in Parkinson's disease. Important if people have neuropathy or to have vitamin B12 and folate checked, because levodopa can actually decrease the absorption of those vitamins, and that can contribute to neuropathy. So that's one important thing to know about with neuropathy, but that also can be checked, and there are medications that can help with that. For instance, I'll actually go over them in the next slide here. So things for pain, so one is physical therapy. So for a lot of types of pain, physical therapy, exercise, and stretches can be helpful. There's some studies showing that massage can be helpful in Parkinson's disease. Acupuncture can sometimes be helpful for people's pain. Working with a pain psychologist can be helpful to help with coping with pain, how to manage it. I went to a pain lecture, and it had some very dramatic photos. It had a photo of actually a man who was on a construction site, had jumped off a ladder, and then landed so a nail was going through his boot. And they showed a picture of the photo, and they took him to the emergency department, and they wanted to get his boot off to kind of see the extent of the injuries, and he was in so much pain they couldn't take his boot off. So eventually they actually had to put him under anesthesia, and when they took the boot off, they found the nail was between his toes. And I bring up that story because the mind is so powerful when it comes to how we deal with pain. And I want to make sure that we don't underestimate the importance of a pain psychologist in dealing with pain. Sometimes people with pain feel like the pain is never going to end, and if they can learn to breathe through it, know that the pain is going to wax and wane just like everything else, that by itself can make the pain less. So we don't want to lose sight of how powerful the mind is with that. As far as medications go, anti-inflammatory medications like ibuprofen can be helpful for some kinds of pain. Tylenol can be helpful. Those antidepressants in the SNRI class can be helpful for pain. Medicines like gabapentin and Lyrica can be helpful. And then sometimes, and there are some studies to back this up, narcotics can be helpful. In Colorado, cannabis is also something that we will sometimes use for pain. With pain management, some of I think the most important principles is that when I talk to patients who are having pain, that we always want to focus on function rather than pain control. So when I talk to people about pain, I'll talk to them about what are our goals in terms of, do you want to walk, do you want to be able to come to Parkinson's voice a few times a week, hang out with your friends, sleep better. But we always make the focus on function rather than on eliminating pain, because for chronic pain, most of the time we're not going to make it go down to zero, and we're not going to be able to eliminate it. And so we need to learn how do we live with pain and how do we make function as good as possible. That also ties into having shared expectations and shared goals when we work with pain. If people with pain are having problems with sleep or mood, we need to make sure those are treated, because if people aren't sleeping well or they have depression, it's going to be really hard to get their pain under control. And lastly, I put up here mindfulness-based stress reduction, or MBSR. And so this is an 8-week program that was developed at Boston University. There's a book called Full Catastrophe Living, and there's a number of courses that have MBSR classes, but this is an 8-week program that involves mindfulness, that involves yoga, that involves breathing exercises, that involves focused body relaxation, and has been shown to be helpful, not just for chronic pain, but definitely for chronic pain, but also for depression, anxiety, and other disorders. And so to wrap things up and sum things up before going into questions, so important to get your memory tested, to not trust your memory about your memory, to talk to your doctor about non-motor symptoms that you're experiencing. So if any of the things that we talked about resonate, make sure you write those down. Come to your doctor with a list to make sure that the right things get covered. Don't go back and complain that your doctor didn't ask you about it. Take that on yourself to do that. If you're having issues with fatigue, balance, or lightheadedness, make sure you get your blood pressure checked, and importantly that you check your blood pressure lying down for a few minutes and then standing up for a few minutes. That just checking and sitting, you might miss orthostatic blood pressure. That just saying your blood pressure might be normal, but it's a drop in blood pressure that causes these symptoms. Important to get your skin checked every year, to get your bones checked. It's important to know that medications that are used for Parkinson's and other medications can affect memory, they can affect sleep, they can contribute and cause hallucinations. Important for your bowel to make sure that we get plenty of fluids and fiber every day. Important across the board for all these symptoms to stay active physically, mentally, and socially. Important to know that there are medications available for almost all the symptoms I talked about. So there's things to help with thinking and memory, to help with mood, sleep, energy, autonomic symptoms, and pain. So these are things that are treatable, they're worth bringing up. Coping with these symptoms can be enhanced through mindfulness, through social connections, through activity, through counseling, and then importantly, and where I'd like to end is talking about resilience. So this idea that we can live well with Parkinson's by focusing on meaning, what brings us meaning in our life, finding opportunities for joy, and keeping love in our lives. And so with that, I'd like to close and open things up for questions.
Car, ball, and man. Those are my 3 words that I had for my mental.
Oh, okay. Yep.
2 days ago. But you didn't say anything about light therapy. What do you think about light therapy?
About, yeah, sure, for mood?
Yeah.
Okay, yeah, so that's a great point. So light therapy, the question is about light therapy. So there's a disorder called seasonal affective disorder. And what seasonal affective disorder is that particularly during the winter, and particularly for people who are living in places like Seattle or Northeast where they don't get a lot of sunshine, that lack of sunshine can affect mood. But even in places like Dallas, that extra light can be helpful. And so if you are a person who finds that your mood tends to decrease in the winter, then light therapy, and there are different light things that can be used to increase light in your life. Yeah, it can be really helpful for mood. So I didn't mention that, but it's a good point. Yeah.
You have presented so much good and useful information. Is it possible to get copies of your slideshow?
I think so, yeah. I'm happy to share this slide set with Parkinson's Voice, and if they want to post it and share it, that's perfectly fine with me. And I think this whole talk will also be on the Parkinson's Voice website. So if you wanted to watch it again, maybe you need help going to sleep, you can watch as many times as you want and take notes, but I'm happy to post my slides.
I was just told that it'll be posted on Friday along with the recorded version of the presentation.
Great. Okay.
Hallucinations. They may not be troublesome at times for the patient, but when they become more violent, they become more scary, they're threatening to get a gun to go kill the deer they see in the woods. How is the best way for the caregiver to handle that when they really don't want to see them medicated? But what's a good way of dealing with that to help the person get beyond it?
Yeah, so a couple of things with that. So it's a great question, and just to kind of pare it down is that hallucinations can be scary. Hallucinations can actually cause safety concerns. And so one of the things that I will do, and this is true for dementia and for hallucinations, when it comes to safety, some of my big things are are there any firearms in the house? So if people have hallucinations, I recommend either get the firearms out of the house or have them locked up or whatever, so that doesn't become an issue. Because again, we don't want it to find out it's a problem after somebody gets shot. So I take that very seriously. Similarly with driving, if people are having problems with thinking and memory or hallucinations, to make sure they get tested. Third, if people are having hallucinations that are scary or problematic, definitely getting your doctor involved to try to treat them. Sometimes, as a care partner, you can help be with somebody and you can help comfort them, but that's not always the case. So sometimes, holding a hand, letting know that things are past, sometimes taking them into another room. One strategy that we actually are working on, there was a great story on This American Life about using comedy improv for people with dementia or people with hallucinations. And so sometimes if people are seeing something, the easiest thing to do is to just agree with them and say, yeah, there are some people outside, and in fact they're washing the windows, let's go watch a television show or whatever. So sometimes it's easier to accept it and then to move on than it is to argue with them about it. But sometimes it can become a problem that it's hard to get around. And I have had patients, families who have had to leave the house or have had to call the police or things like that. And so it's not always possible, unfortunately, to convince somebody that what they're saying is not real. And so again, the best thing is to try to address those early. And unfortunately, when I see people in clinic, sometimes those can be things that may lead to being in a memory care unit or assisted living or something where they need extra help because they do become a 24/7 safety concern. So it's also important for families, both for the patient and for themselves, is that we always want to keep people safe. And so if people have hallucinations that are threatening and that are putting people at danger and that we can't treat with medications, and sometimes that is the best option. Even though people want to stay at home, sometimes it's not safe.
Thank you, I really enjoyed your lecture. You briefly mentioned about cannabis, and I'm just wondering, even though it's not legal in Texas as yet, what list of symptoms does it actually help in your experience?
Yeah. And for people who are interested in learning more, I think on the Parkinson's Foundation website, there's a whole hour-long webinar that I did on cannabis. But in a nutshell, the things that I've found to be most helpful, sleep, anxiety, nausea and appetite, pain, those are the things that tend to, and also muscle spasticity. So those are the things where we have fairly good evidence, mostly from other conditions, that they can be helpful. For motor symptoms, things like tremor, slowness, and stiffness, I have a few patients who feel like that cannabis has been helpful, and cannabis is a kind of a long and tricky topic. So there are now over 100 cannabinoids, so chemicals in cannabis, and so depending on what strain you're getting, you can have very different effects. So there are strains that you can get that increase your energy, and there are strains that can help you fall asleep. And so there's a pretty wide range of strains, and there's the main two things that we focus most on are CBD, or cannabidiol, and THC. THC tends to be more helpful for things like pain and appetite. CBD tends to be more calming, so for things like sleep and anxiety. That's kind of, in a nutshell where I would go with that. But it's not something that we use, even in Colorado, it's not something that most of our patients are taking or most people are finding helpful for the motor symptoms of Parkinson's. Yeah.
I've got peripheral neuropathy in my legs, and my doctor wants me to stop taking narcotics. Have you found Lyrica to be helpful?
Okay, yeah, so the question's about peripheral neuropathy and trying to get off narcotics, and it can be tricky with peripheral neuropathy, and depending on how painful it is. So medications that are sometimes helpful include Lyrica, but it's not always helpful. Gabapentin can be helpful, but not always. Cymbalta is another one, or Effexor is another one. And those medications can sometimes be helpful, but they aren't always helpful. If it's very focal, so in a particular location, sometimes things like lidocaine cream, lidocaine patches, capsaicin cream can be helpful. Sometimes nerve blocks or other injections can be helpful. And there are times, unfortunately, where narcotics, are our best option, our only option to keep things under control. With narcotics, I like to try to keep people at as low a dose as possible, and really try to use them in a mindful kind of way. So if the neuropathy is interfering with your sleep or it's interfering with exercise, then you might take a short-acting narcotic around those times, but really try to minimize the total exposure to narcotics.
Thank you.
Sure.
Doctor, I just wanted to say once again, reiterate what some of the other people have said. This is an extraordinary lecture. It was so much information, and it was just presented at a level that everybody could understand, and I really appreciate it. I did have a question, but I'm like the man in the cartoon,
Yes.
and it's gone away.
All right. Well, it comes back, we'll come back to you.
I have a question about the visual illusions.
Yes.
You didn't elaborate on that are they like floaters as well?
Yeah, so visual illusions are not floaters. So floaters is actually something in the eye. In your eye there's actually a bunch of kind of like clear jelly called vitreous, and that's what causes floaters. So the visual illusions in Parkinson's, so a few things. So there are dopamine cells, and there are changes actually in the retina. You know, we talked about that Parkinson's affects things outside the brain, and the retina is actually one of them. So Parkinson's can affect the retina, and it also has effects outside the basal ganglia, including parts of the brain that are important for visual processing. So that's why people with Parkinson's get illusions. In general, they're not something that I treat unless they're problematic or scary, but a lot of times just talking about it can be reassuring. And it's also important to make sure that it's not a floater or glaucoma or cataract or something like that. Yeah. Sure.
When I was first diagnosed 3 years ago, I read a lot of materials and they talked about you should go to a physician a neurologist who's a motor specialist.
Mm-hmm.
So much of what you provided in your talk, I do not get, we don't have that battery of questions when I go see my neurologist. I get some of that with my general practitioner. So this last year, we had this conflict between a cardiologist and a GP about my blood pressure.
Mm-hmm.
Finally, I said, that's it. I'm not taking any more blood pressure medicine. So I had to be kind of like the referee between doctors to make sure they all were looking at the same information. So my question is, what type of doctor can we look to help us with all of these non-motor symptoms? Or should we be able to do this with our internist or general practitioner?
Yeah, that's a good question. So the question is who is the best doctor to work with these non-motor symptoms? And in general, I would say the answer would be a movement disorder specialist. And so, for instance, in our fellowship, and I think in most fellowships, that we now recognize that non-motor symptoms are part of Parkinson's. And so, for instance, the orthostatic blood pressure is something that every movement disorder neurologist should know about. A lot of neurologists do know about it, and so again, it kind of depends on the neurologist. Some neurologists who see a lot of people with Parkinson's know about the treatments for low blood pressure and how to manage it. Same thing with problems with thinking and memory. And you're bringing up a pretty common problem, something that I hear a lot about, which is that my doctors don't talk to each other. There's kind of gaps in care, and so sometimes it can be difficult to coordinate. And unfortunately, sometimes it really falls back to the patient or the patient and their care partner to try to be the captains of the healthcare team. And it's something that at the University of Colorado and our palliative and supportive care clinic, we've tried to take off the shoulders of patients and caregivers and try to be the captains, but that doesn't always happen. I would say another thing, just to think about it is definitely trying to find a doctor who is able to listen, which is not all doctors, unfortunately. And so you might have a doctor who doesn't know all of this, but if they're able to listen and they can reach out to people or do some research for you, that can be almost as good as somebody who has all the answers.
I wanted to mention one thing. If you're not familiar with the Davis-Finney Foundation, they have a manual called Every Victory Counts, and it's online. And what I want to mention is in the back of the manual, there is a checklist that you can look to before you go to your doctor's appointment, and it brings up all of these different symptoms. It's a really good one because you may not be aware of that a particular symptom is related to Parkinson's, but the checklist goes through everything so that you can look through it and go, well, I actually have that. Let me talk to my doctor about it. So it's the manual, Every Victory Counts. It's online. It's with the Davis-Finney Foundation. We have a copy in our library, and now we have a question right here.
Great program, thank you. I wonder what nocturnal leg cramps are versus RLS.
Sure. I didn't spend a lot of time talking about nocturnal leg cramps, but nocturnal leg cramps are aches and pains in the calf. Sometimes it's like a Charlie horse in the calf, and that's a nocturnal leg cramp. RLS, on the other hand, is really more, oftentimes people describe it as a creepy crawly feeling. And if they get up and walk around, that creepy crawly feeling goes away, so they're pretty distinct. RLS tends to happen mostly at night when people are sitting and sitting still, but sometimes people with RLS can have it during the daytime as well. And then the treatments for the two are different. So if you're having problems with nocturnal leg cramps and pain, magnesium, sometimes creams with magnesium or calcium, bananas, quinine, muscle relaxants can be helpful, whereas with RLS, we want to make sure we don't miss iron deficiency, anemia, which can cause RLS. Certain medications like antidepressants can make RLS worse. And then dopamine therapies and the other medications I mentioned would be the mainstays of treatment for RLS.
This is just a quick natural to add to what you can do for the leg cramps. Pickle juice.
Pickle juice,
It
okay.
really works. Tastes nasty, but it works, I promise.
I don't think it makes any difference.
Yeah, so it's pickle juice and soap at the foot of the bed to the left.
Watch that blood pressure.
If you have a question, go ahead and raise your hand up high so we can see you.
Does RLS occur in the early morning hours?
So the question is, does RLS occur during the early morning hours? It's not typical, but it can. So the most common time for RLS, and usually when RLS starts, it's in the evening around bedtime. But as RLS progresses, sometimes people do notice it in the early morning or during the day. Other things that can cause pain in the early morning can be a neuropathy. Sometimes dystonia or medications wearing off can be associated with some pain in the legs. So those would be other things I would just kind of have on the list, particularly if you're not having anything around bedtime. To have it just in the morning would be a bit unusual, but could happen. Okay.
Question over here?
You're having illusions. Can that turn into hallucinations?
Yeah, so the question is, can illusions turn into hallucinations? And I don't know if it's been well studied. So there was a paper that came out over the last few years that suggested that hallucinations were actually a lot more common than we had realized. Again, probably because people weren't bringing it up with their doctors. And so hallucinations can include what are called presence hallucinations, so kind of having the feeling that someone's behind you even though no one's there. Oftentimes visual hallucinations, sometimes tactile, kind of feeling like something's crawling, or smells or sounds. And I don't know that anyone studied whether illusions make you at higher risk for developing hallucinations later. Probably the biggest predictor of whether or not you'll develop hallucinations is having problems with thinking and memory. So again, if people just have illusions, I don't make too big a deal out of it. We'll provide some education around it. But a bigger issue and a bigger predictor of whether you would develop hallucinations would be if you're having problems with thinking and memory or developing dementia.
You mentioned fluorocortisone for orthostatic hypotension. Given that it's a cortisone drug and you're on it for who knows how many years, is that a danger for any other medical problems?
So the question is about fludrocortisone, or the other name for it is Florinef, and whether it's a danger to be on it. So some corticosteroids, like prednisone, which sometimes people will take for rheumatoid arthritis or other autoimmune conditions, can have significant problems, for instance, with thinning of the bones and with cataracts and things like that. Fludrocortisone is a pretty specific, and it doesn't have the general systemic effects that those steroids do. And so it's not something that if you come off it that you're going to have adrenal suppression, and it doesn't seem to be associated with cataracts or some of the other things that you get from prednisone or more general steroids. Yeah.
I'd like to take this time to tell you that my takeaway from this is that you have to be proactive. You have to be active in your stance. I mean, you have to be active because of the exercise, but you have to also include everybody. And I think that's important, the three things that I got from it.
Great.
Thank you.
Yeah. Good points.
Dr. Kluger, could you expand a little bit more about the impulse control disorder, specifically about the gambling and how this kind of occurs in the medications that are involved? It's such a serious issue and people don't want to really bring them up, you know?
Yeah, so I can go over that in a little bit more depth. So the impulse control disorders, So these include, as I mentioned, gambling, and so it can look like a gambling addiction. It can be internet shopping, internet pornography, other sexual activity, extramarital affairs, working with prostitutes, something called punding, where people will take apart a radio and put it back together, or compulsively count pebbles or things like that. So all these things are kind of have the common denominator that people feel kind of compelled to do them. And they have this impulse to do them that they're unable to control. And if we think back to the earlier slides on the lecture, I talked about the basal ganglia is not just about movement. And so one of the other things that the basal ganglia is important for is for motivation. And so one side of that is apathy, where people don't want to do anything, and the other side of that is that if it gets supercharged, is these impulse control disorders where people are compulsively and they can't stop themselves from doing these things, and also from I guess, increasing the sensitivity of the reward circuit. So these things all have the capacity to bring about big rewards, and people can become addicted in that way. And there's a lot of evidence that these are common, that they can in fact actually double-digit percentages of people with Parkinson's, 10 to 14% depending on the study. And also that they tend to be most related to dopamine agonist medications, but levodopa, amantadine, and even DBS have been associated with these problems. So I think it's important that as a community that we're aware of them, and that we know that the cause of them is the treatment. It tends to be the treatment of Parkinson's, not Parkinson's itself, and that lowering the treatments can generally improve them, although sometimes they can become refractory, and working with a psychiatrist can be helpful. Some of the risk factors for them is that if people have a prior history of gambling or drug use, then they're obviously at higher risk. Men tend to be at higher risk, and also when you look internationally, Americans tend to be at higher risk.
That is all the time we have for questions. Let's give a round of applause to our speaker today.